Bueno, hola, buenos días a todos y muchas gracias por la invitación y esta introducción. Voy a cambiar a inglés, perdón por este. No sé si I don't know if my English will be better than my Spanish, but we will see. So, the topic was to talk a little about optimization of partial nephrectomy. So we'll try to do so. Just let me try it. I don't know how it works exactly. Yeah. So when we speak about optimization, what is the meaning first of optimization? If we look at the dictionary, the Collins, optimization would be an approach that would tend to achieve best results and to run a plan with the maximum efficiency and make a system optimal. So if we try to apply it to partial nephrectomy, looks like that it defined the optimal partial nephrectomy. So the optimal partial nephrectomy would be the grail for every surgeon that would be involved in nephron-sparing surgery. And we will try to define it. And prior to optimize, we need to remind what the grail is. And actually, when we treat a patient and we want to perform a partial nephrectomy, we will have several objectives. The first one would be to be efficient in terms of oncologic efficacy. What does it mean when we want to perform a partial nephrectomy? It means that we will achieve a negative surgical margin and we will try not to make a tumor breach or a tumor spillage in case of cystic tumor. Our second objective will be to try to preserve as much as possible the kidney function. What does it mean? It means that we will try to preserve as much as possible of the normal parenchyma, so to make a minimal margin resection, and we will try to limit the extent and also the length of the ischemia. And then the third objective will be the safety of our procedure. So we will try to achieve for our patient surgery that we will not be complicated, no postoperative complication. We'll try to do it on a minimally invasive way, and if possible, trying to do an enhanced recovery surgery, and if possible, a day case surgery. And finally, we'll try to look at the global patient care in order to take into account the total aspect of our patients. So, how to optimize our partial nephrectomy? I see three axes. The first one would be to optimize the technique of our surgery. The second one to optimize the patient education, and the third one to optimize the care pathways. So let's start with the first axis, technical optimization. What can we do to optimize our technique? First of all, I think robotic assistance will be a way to optimize the technique. So I just present here some of our some data about our experience. This is the way how our approaches for partial nephrectomy changed over the time, starting before 2007 up to 2016. And you clearly see here that regularly the open approach decreased, and that we completely shift to robotic assistance, and that the pure laparoscopy disappeared completely. Since 2017, we do not perform any open partial nephrectomy, and all our procedures are robotic assisted, even for big tumors and complex tumors. And these are some of our results. We have in the department the experience of over 1,000 partial nephrectomy, but we compared here our results between open partial nephrectomy, open partial nephrectomy here, and robotic-assisted partial nephrectomy up to 2016. And you see here the benefit to the shift to the robotic assistance, with a huge decrease in terms of length of hospital stay for our patients, but also a decrease in terms of postoperative complications. Oops, sorry. So the decrease was about 12% for intraoperative complications, 7% for medical postoperative complications, and 9% for postoperative surgical complications. At the same time, you see that we also decreased the number of transfusion rate, and we also improved the renal function for our patients in postoperative. However, what we've seen also is that the shift from open to robotic assistance is not only the key, and we clearly saw in our experience that the results were improved over time. And when we compared our first robotic assisted partial nephrectomy from 2010 and 2014 compared to the years after, between 2015 and 2016, we thought that at the beginning our results were not so good. And you see that we had a higher number of positive surgical margins, meaning that the technique has to be trained and the technique has to be improved. And hopefully with the time and with the experience, we finally were able to have better results that we have previously with open approach. Second way to optimize the technique is 3D model and image-guided surgery. We will talk about it a little more later in the morning. However, we clearly think that surgical planning for this kind of complex surgery is the key. And for this, we need an excellent CT scan with 4 phases. And the goal will be to use this CT scan to create this kind of 3D virtual model. The objective is to be able to understand the patient-specific anatomy. And this will allow us to improve our surgical planning in order to clearly define the tumor complexity, in order to imagine the resection margins, in order to clearly see the contact between the tumor and the vessels and the collecting system, and also to plan our clamping technique. This kind of model can be easily plugged into the robot and will allow us to perform a 3D model assisted surgery with an intraoperative navigation, as you can see here in this video. So we are able to follow with the 3D model the dissection of the arterial branches and the vessels in order to define the arterial branches that we are looking for and that will directly feed the tumor in order to perform superselective clamping, for example. Third way to optimize our technique are the ischemia sparing techniques. So as you know, the ischemia will have an impact on the postoperative renal function for our patient. Even if we clearly know that the preoperative renal function of our patient will have a great impact, the ischemia still have an impact. And there's no better model to evaluate it than looking at what happens for patients who have a solitary kidney. And these are the results published about 362 partial nephrectomies on solitary kidneys. And as you can see, in multivariate analysis, the length of ischemia will appear as a predicting factor of acute renal insufficiency, but also for new on stage CKD. So many techniques have been reported in order to try to diminish the impact of the ischemia. One of them is the early unclamping technique. The goal, the way that it is performed is to unclamp after the first layer and before the capsular rhinography. We have an abundant literature on this technique. The advantages is that it can be performed in every case, even if you clamp the trunk of the artery or even if you are doing super selective clamping. It will allow us to assess the quality of the hemostasis before doing the rhinography, and it will decrease the warm ischemia time. And on my point of view, I don't see any disadvantages of this technique. Second technique would be the super selective clamping. So as you saw, and especially with the precise surgical planning, we are able to individualize the tumor feeding arteries. The goal of super selective clamping will be to avoid to be in a hurry in order to have sufficient time to make a nice tumorization and make a nice a nice repair. So you have here the case of a VHL patient with 6 or 7 tumors, I don't remember exactly. And so for sure, in this case of patient, if you want to remove all the 6 tumors with a truncular clamping, then you will have warm ischemia time that will exceed the 20 minutes that we have usually as a limit. And so for this kind of patients, it's really a technique that will allow to make super selective clamping at the time, meaning doing sequential super selective clamping, only clamping the branch that is of interest when you are working on a specific tumor. So the advantages of the technique is especially for hilar tumor, because for hilar tumor you will have to anyway dissect all the arterial branches in order to free your tumor. It is also really interesting for big, complex and multiple tumors. As I said, sequential clamping will be feasible, and it will decrease the extent of ischemia. However, there are some disadvantages, mainly based on the fact that the arterial distribution is very variable from one patient to another, and so the planning will be mandatory. Without planning, no way to succeed. Sometimes you also have to know that super selective clamping will not be totally efficient, and you need to tolerate a small bleeding. Usually it can be frightening when looking it with in the scope of the optic, but actually the bleeding is minimal. It will require a precise and deep vascular dissection to reach to the 4th or even later order arteries. And I have to say that it's not a good technique for mid-pole cortical tumors, and these ones are bad candidates because they will be fed by several branches coming from multiple second-order branches. Fourth, I just wanted to say a word on tumor enucleation. Tumor enucleation, well, we have to find the limit between enucleoresection and true enucleation. What do we know about enucleation? Globally, we know that it is safe to perform an enucleation. The goal will be to follow the pseudocapsule plane. We have an extensive literature on it. We have a proven oncologic efficacy. And the advantages will be that it is an anatomical way of resect the tumor, because you will follow a natural plane. It will so far decrease the bleeding. You will spare as much as possible of healthy parenchyma. And you will do it de facto for a sinusal tumor, as you can see in this small video. However, there are some disadvantages. The risk of tumor breach will depend on the pseudocapsule strength. And we have very few data, especially in terms of oncologic safety for Fuhrman grade 4, and in case of microvascular embolism, for example, or in case of hilar fat invasion. To conclude about the technical optimization, I would say that our goal would be to perform a personalized surgery. And we must adapt our surgery and our technique to the case specificities, meaning that we would have to discuss a direct tumor approach compared to a hilar control. We would have to discuss a minimal dissection versus an extensive kidney dissection, a clumping of the main artery, or a superselective clumping, or an off-clump procedure, or an anatomical tumor devascularization. Will we do a resection, or an enucleoresection, or a true enucleation? And finally, how will we repair the tumor bed? Second axis in the way to optimize partial nephrectomy would be about patient education. How to enhance our patients' education. We found that maybe using 3D printing would be a way to do it. And these are the results of our very first and initial series using 3D printing for, at the time we did it for 7 patients. And what we showed is when we showed the 3D printed model to our patient, we improve the education of the patient, and we improve the comprehension of what we will do, of what we explain to him, of what is his disease, and of the risk of the procedure that we will perform. And as you can see, we were able to improve all of this from 16% to 15%, depending on what we are looking for. We reproduced this study, and I will talk about it later in the morning. But what you can see directly is that apart to improving the comprehension of the patient, it's also something that is really really appreciated by the patients. Last point is about clinical care pathways. We developed in the last 3 years two clinical pathways for our patients. The first one was an ERAS pathway, and the second one, a day case surgery program. We performed the first day case partial nephrectomy, robotic partial nephrectomy, in October 2015. And following this, we were labeled by the government as a pilot center for minimally invasive outpatient kidney cancer care. And the idea that there's no reason that all patients would have the same clinical pathway. Not all patients are the same. No reason that all of them would stay in the hospital for 3 or 4 days, I don't know. So let's talk a little about this case. 41-year-old male, no medical history, was diagnosed with an asymptomatic 3 centimeter left renal mass. As you can see, renal 7A, not so complex tumor, Padua 9A. What would you do? Would you observe it? Would you biopsy it? Would you ablate it? Would you cut it? What we did is I don't know if it is possible to launch the video. You would need to click on it, if possible. Anyway, so we decided to do a simplified robotic partial nephrectomy. Simplified meaning that we are doing a tumor-targeted dissection, going directly into the tumor, meaning that we do an off-clamp procedure, and at the end of the procedure, we do not leave any catheter, not any drain. For this kind of patients, so we have a specific clinical pathway that is reproduced here with many steps, and all the steps are coordinated by a nurse. And we call it the Ambulance protocol. So we applied this protocol nowadays to more than 80 patients, but I will show you the results on the 56 first cases. So the first thing that you have to notice is that when we did 56-day case partial nephrectomy, it was among 286 robotic-assisted partial nephrectomy within about 2 years. So what does it mean? It means that less than 20% of our patients were candidates for a day case partial nephrectomy. As you can see here, all of these were highly selected because you see that the mean age was 57-year-old and the mean tumor size was not so big, 2.7 centimeters. If we look at the complexity, however, most of the patients had moderate complexity tumors. So not only the low complexity tumor patients were candidate. And finally, what happens in terms of morbidity? Very short surgeries, and I think it is a key point in order to be able to perform day case robotic assisted partial nephrectomy. So you see less than 2 hours procedures. In 4 patients, we did not succeed, meaning that we had to keep them at hospital. One because of a pain that was not controlled, the other one for nausea, a third one for anxiety, and the last one because of intolerance with tramadol. But we had no post-operative complication and no rehospitalization at day 30. And as part of the study, we also looked at the patient satisfaction to be involved in a day case surgery program. And we compared it to the patients that were hospitalized and that were part of our ERAS protocol. And what you can see here is that patient satisfaction was as high for patients who were in the day case program than patients who were hospitalized. So we are not decreasing the quality of what we are doing when proposing day case partial nephrectomy. A consequence of that, in implementing day case surgery program and ERAS protocol, as you can see here, is that we completely change our length of hospital stay. If you look in 2014, our mean length of hospital stay was 5.3 days. So 97% of the patients were hospitalized for more than 3 days in our department. And if you look in 2017, our length of hospital stay, mean length of hospital stay was 2.4 days. And as you can see, 18% of them were day case, 4% only stay for 1 night, 39% for 2 days, and very few, 17% for more than 3 days, where there were 97% in 2014. So in conclusion, I would say that optimization nowadays would be personalization. And the optimal partial nephrectomy would be the personalized partial nephrectomy, personalized on several things, on the tumor characteristics, on the case complexity, and on the patient characteristics. And by doing so, I think it's a way to particularly improve the way that we manage complex situations, and also it usually allows to spare more parenchyma than we could expect. Thank you very much for your attention.